So we're going to cover the management of severe pain in mountain environments. We've got about an hour to do that, so I think we should have lots of time. I am the medical director for Canada Access Public Safety, and in terms of mountain medicine, one of my really key interest areas is making the medicine fit the operational considerations. So that's going to be a bit of a theme through this talk. Sometimes operational problems or considerations dictate what medical treatment is appropriate, and that's certainly the case in terms of management of severe pain. I thought this might be a good update because it's been, it was 2013 when ICAR last sort of published or made recommendations or pronouncements about this topic, the management of severe pain. So I thought things have changed a little bit, and it might be a good time for an update. Those are your objectives. Maybe draw your attention to objective number 3. That objective, there could be a couple of contexts there. Feeling confident managing severe pain, that might be you rolling into the scene as you roll up to the subject at the scene of an accident in the mountains. Or the other context for you might be what could my operation do about giving our responders a pain management plan, coming up with a structure over the summer that might work for your operation. So it might be an operational context, or it might be your own individual context, having a plan that's well organized and easy to carry out when you roll in. I always have a couple of hidden objectives as well with these talks. And the hidden objective for this talk is that providing good pain management when we're working as first responders in mountain environments is actually good for our health. So that's something that's come up a little bit recently, and it's just an interesting way to approach this. So it's actually good for us as responders, so we'll talk about that a bit more. Okay, so we'll kick things off with a scenario here, so I'll let you read through that. The scenario is mainly just to provide some context or to give us a picture, something to move forward with the talk. So we've come across the scene of an accident in a mountain environment. Kind of sounds like this skier's been avalanched and probably taken down into the trees. So you assess the situation, and you're going to go and help. So the injured person here is shivering, looks pale, appears shocky. It's a little bit confused. He's got some scalp bleeding. His pulse is a bit rapid, so is his breathing. He looks pale, and he's cool to the touch. He's got left chest pain, so that's concerning, and he also has severe pelvic pain. We'll talk a bit more about pain scores in a few minutes, but his pain score is 10 out of 10. So this subject is in really big trouble. So a couple of questions. Given that it's a difficult location for this rescue, and given that our patient is shocky and kind of appears to be in pretty severe trouble, wouldn't it maybe be better just to have him man up, get the packaging done, and just kind of scoop and run, hand him over to a higher level of care? So we're going to look at, in that sense, why the answer is there's a lot we could do in terms of pain management for this patient, despite the operational considerations and despite the patient's condition. So we'll take a structured approach to that. So if we're going to treat his pain, how would we assess his pain, and how would you monitor it during the operation? And in terms of treating his pain, what exactly would be the options? We'll run through a whole bunch of options in kind of an organized way. So this picture on the right is just a distraction. That's my partner Kelly bouldering down in Joshua Tree. You can probably see from the photo that I was doing a really great job spotting here. It's all good. Okay, so here are the advantages of providing effective pain management in the field. if we're busy and working hard at it, it reduces our emotional response to a patient's distress and their severe pain. And in the long run, I'm a pediatric surgeon. I work at the Children's Hospital, my day job in Calgary. And in the long run, having to be faced with distressed patients, especially children who are suffering from severe pain day in and day out, starts to take a toll. So this might especially be interesting for the ski patrollers that respond to things probably almost every day. Focusing on pain management also helps you focus on operational considerations. So for my guys in K Country, the operational constraints and problems and considerations, they can really have their hands full during an operation. So if there's good pain management going on, that often frees them up to really focus on the operational problems at hand, because that's where some serious stuff can happen. The next point there, does good pain management improve the quality and the accuracy of your assessment and your treatment? This is an interesting point because pain is usually felt to be protective. If we feel pain, we protect ourselves when we're injured. On the other hand, way back in the day when I was training, it was thought to be a really, really bad idea, a never do, to give pain drugs to children who had come into emerge and who were thought to have appendicitis. Because as surgeons, we thought that perhaps that would mask the signs of appendicitis and we wouldn't be able to diagnose them effectively. So that's come around full circle, and it turns out if you study that issue carefully, children with appendicitis who are given good pain management in emergency, say morphine for example, the assessment of their appendicitis is far more accurate and their treatment outcomes are far better. So we flipped 180 degrees on this. Never give pain drugs to a suspected appendicitis case. It's very important to give them so that your assessment and your treatment can be done accurately. So in that sense, good pain management does improve patient outcomes, especially in our world in terms of trauma outcomes. It does that probably in a number of ways, but one of the ways it does that is by reducing the stress response and the physiologic stress of the injuries. The last point is kind of interesting. It is, if you're a first responder, it would be kind of considered everywhere now that providing pain management in a structured way is an ethical requirement, so it's just the norm. And we're all expected to do that. So we'll talk about some ways to do that you might not realize are tremendously effective. Okay, so we'll dive in here just a little bit of pain theory. We won't spend forever on this, but there's a definition of pain. There's an international association for the study of pain, and this is kind of paraphrased a little bit, but that's the definition of pain. So it is an unpleasant sensory and emotional experience, and it is associated with actual or impending tissue damage. Not always, but almost always, and especially in our context. So what's maybe more important about this definition is what pain isn't. So I wanted to point out that there is no pain center in our brains, so we can't scan the brain or put a thermometer in there to measure pain. That's not how we assess pain or measure it. So pain is a bit more, I use a speedometer analogy, and the point is there is no pain speedometer inside our brains. So think of yourself driving down the highway somewhere here in BC, and maybe you're actually going 100 kilometers an hour, but your car has no speedometer. So if it's like today, it's a sunny day, it's daylight, you're well fed, you're well rested, you're familiar with the drive, there's not too much traffic. it may or may not actually feel like you're going 100. It might actually feel like you're going a little bit slower than that. So if you had no speedometer and were asked how fast are you going, you would just, under those conditions, you might feel like you're going 80. So you could report that you're going 80 or 8 out of 10. On the other hand, if it's like it sometimes is driving around BC, especially with my tires, it might be dark, it might be cold, maybe you're stressed out, you're in a hurry, the road's icy, the visibility's terrible, it's the middle of the night, driving snow, we've got the Star Wars effect. So if you were actually going 100, but you had no speedometer, and you were asked how fast are you going, it might actually feel like you're going way too fast. So you might report a higher number. So that's kind of how pain works. There is no speedometer for pain in our brains, and that's why we score pain on a scale from 0 to 10. And we'll talk a little bit more in just a sec about how to do that. Okay, here comes the quiz. So we'll put that practical knowledge about how pain works into use here. So here we've got 2 patients. They're different size, one big and one small. And we'll just hypothetically say that they both have exactly the same fractured femur. So, kind of the idea is that they both should have exactly the same pain. You're planning to use, or the advanced care provider with you is going to use IV morphine to treat them. They both get exactly the same dose on a per kilogram basis, so they get exactly the same dose of morphine. So you expect that they will each have the same level of pain relief from that same dose of morphine. So true or false? It's a quiz. How many would say true? Oh, good. I see a couple of hands going up in the back there. So that's actually pretty good. The answer, I guess, would be false. So if I'm preaching to the choir here, that's great. But when I trained, the answer was true, absolutely true. And that's how we have practiced medicine for decades in the hospitals. The dosing is standardized on a per kilogram basis, and you expect it to work. And when I was training, you were sometimes kind of surprised when it wasn't working that well, and you had to give more, look for an explanation. But it's just the way pain works. So, if in your mind the answer to this question is false, then that's great. You understand how pain works, and pain treatment, I think, to some extent as well. Okay, we're going to turn to the Simpsons here now for the quick review of pain scores. Is everybody familiar with scoring pain, scale of 0 to 10? It's a score. It's how you ask how bad somebody's pain is. There's pain speedometer. So you would ask them, what is your pain on a scale from 0 to 10, compared to your worst pain ever. So this clip comes from an episode called "Stupid Sexy Flanders." Turns out that Ned Flanders is an excellent skier. He's an expert skier, but he wears a skin-tight one-piece ski suit, kind of like maybe I did back in the 70s. And that was an issue for Homer. So Homer's gotten out of control. He's skiing down the hill. In this sequence, his leg snaps and spins around 180 degrees, and he says, "Ow, this is the worst pain ever." So pretty straightforward. His pain score is 10 out of 10. Does any Simpsons fans, does anybody know what happens next? Okay, I see a hand up there. We'll get to it here. This is what happens next. Homer gets crotched by 3 little trees in a row. So now what's his pain score? Well, probably 20 out of 10. But the answer is it's still 10 out of 10 because now this is his worst pain ever. So your pain score is relative to compared to or relative to your worst pain ever. So thanks to the Simpsons and Homer for helping us understand pain scores. So I'll just take a brief moment to to talk about where we treat pain matters. So there's two photos there. In the lower right photo, that's actually me doing a surgery, a burn reconstruction surgery for a young child's hand. That's actually in Peru. And it's a very, very painful procedure, but you can tell from that photo that I'm surrounded by a big team, and all but 2 members of that team are managing the patient's anesthetic. So we have a lot of very expensive equipment that we drag along with us on this type of trip, and people with tremendous knowledge and experience in managing pediatric pain. So I don't, when I'm doing this operation, I don't have to think about pain management at all. I have a huge team surrounding me doing that the whole time. On the other hand, the photo on the left there is a lengthy raise on this house of sky out in the Ghost, and there is a lot going on operationally there. So how you manage pain in these 2 situations is not the same. So this is where the medicine has to work for the operational considerations. Okay, this might be the take-home slide right here particularly for that third objective. So when you're rolling into an accident scene yourself, if you're thinking, how am I going to organize my approach to pain management? What exactly are my options? You only really have to remember 3 things from this slide. You can use psychological measures, you can use physical measures, and you can use medication, drugs like analgesics or anesthetics. So there's just 3 ways or 3 options for managing pain in that sense. And each of those options, there's a few examples there. Some things that are all actually highly effective at managing pain, and we'll talk about each one kind of individually here. Also operationally, if you were getting organized and you wanted to construct a pain management scheme or tool for your operation for next winter, this structure would probably work just fine. ICAR has noted that the first 2 measures, the psychological measures and the physical measures, often get forgotten or missed as really, really important, a really important part of a pain management plan. So their latest update way back in 2013 even reminded us that these measures, the first 2 measures, are often the most important. See a few iPhones come up there. Looks like we're all good to go. Yeah. Oh, well, yeah, I guess what I meant there was if it's dark, it reduces pain scores to make it light. In a hospital context, if it's nighttime, patients' pain scores are often worse just because it's dark. So having good lighting, a warm environment, lowers pain scores sometimes from 9 or 10 all the way down to 5 or 6. So those would be examples. Yeah, we'll talk about some specific measures, and that's great. Yeah, feel free just to. I think we've got lots of time for this talk, so we'll either have lots of time for questions after, or I can answer questions as we go too. That's awesome. Okay, so what about psychology measures? So how do those work? One way they work that might be the most important way is that they reduce the subject's fear and anxiety, especially in children, but in everyone. If you can focus a person's attention away from the pain, that can be very effective. Giving the patient some sense of control when their whole world has just suddenly gotten out of control is also a very important sort of psychological measure. So the advantages of using these measures routinely is that you always have these available. You can always roll into a scene, tell the patient, the subject, your name, tell them that whether you think they are or not, you can tell them that they're going to be okay, you're going to get them to help real soon, you're going to take good care of them, you're going to stay with them, Just simple statements like that will reduce pain scores, again, from 9 or 10 down sometimes to, to 5 or 6 or 7, kind of in that range. So those are important. There is an app for that. What do I mean by that? I was super proud of one of my guys. I won't mention Mike's name, but because he's out climbing this afternoon, he just texted me. But I was super proud of Mike last summer. We had an 8-year-old kid in K Country have an accident. He had a fractured dislocation of his hip, so extremely painful injury. And Mike flew out and did the rescue. So for managing this kid who had severe pain, and getting him packaged and successfully flown out to the advanced care paramedics on his way to the Children's Hospital, Mike pulled out his iPhone and he used a kid's game on his iPhone from his daughter Elsa, and effectively essentially effectively managed this child's pain just with a kid's game on an iPhone. The reason Mike knew that or knew to do that was that we talked about it with our group, and I'd mentioned to the guys that we do this routinely for painful burn dressing changes at the Children's Hospital. So they're fairly quick, but they're extremely painful, and we always, among other things, we always use distraction as one of our primary pain relief measures for children that are having burn dressings changed on an outpatient basis. So it works amazingly well. So again, it can cut pain scores in half, no problem. The disadvantage, though, is sometimes if you're going to have breakthrough pain, in other words, there's going to be some sudden packaging going on, getting that ankle straight or getting that pelvic strap tightened for our patient in our scenario, the pain may break through these measures, and you may have to kind of have another round of them once that pelvic strap is tight or what have you. Okay, the physical measures, so a couple of key examples for our scenario patient. We're going to probably be doing anyways. We're going to be hopefully splinting his fractured pelvis, and that would reduce his pain probably as much or better than any medication would. But strapping that pelvis will be very painful in the absence of other medications. Another key measure for our patient would be warmth, so having a full-length heating blanket. I know those things are expensive, but warmth would be critical to our patient because he does have shock, and if he gets cold, it's part of the kind of deadly triad for hypovolemic shock. So warming this patient would be a key pain control measure as well. I know the blankets are expensive, and I know some of the ski hill operations don't have them or may not have them readily available. But keeping a patient warm, even if it's just one of the glove warmer sized chemical warmers slip down the patient's back of their neck, that might reduce their pain score 2 or 3 points just by a warm feeling. So we're going to talk specifically about some of the drugs, so either analgesics or anesthetics. The good thing with some of these drugs is they're becoming quite a bit more available. So they've been reaching out for quite a few years into the first responder world, and they are there, and they're reaching out into the mountain first responder world as well. So they are becoming more available, but there are some constraints, and no one medication is effective. So I am going to spend a little time talking about Penthrox, or also known as the green whistle. Just a cautionary note, I don't think it'll be the one perfect medication for mountain rescue, but we'll talk about it and try to put it into context a little bit. So here's a couple of medications that you might not think about. We usually think of Tylenol, ibuprofen, so that'd be like Advil, Motrin, and so on. We usually think about these as what you'd use if you have a bit of a headache, or you stubbed your toe or something like that, and you need some mild pain relief. Interestingly, when we operate on kids at the Children's Hospital, they almost all get a dose of Tylenol right before they undergo their general anesthetic. Tylenol and ibuprofen are both very good baseline medications. And you might wonder, well, why would you give Tylenol if they're being knocked right out with a general anesthetic? It reduces how much general anesthetic they need. So the general anesthetic's actually a little easier on their system, and it smooths out the wake-up process, so they're less distressed as they wake up with their painful surgery coming out of the general anesthetic. And it makes very good baseline pain control that we can then build on with stronger meds if we need to. So these meds, sometimes the subject will have them themselves, and in K country, we're able to give these drugs kind of as an assist. If they have them, we'll assist them and let them take these drugs most of the time. One of the disadvantages is if you take a Tylenol pill or an Advil pill, they take a while to work, 20, 30 minutes. But that still might make a big difference in a mountain operation. Okay, Entonox. Entonox is, interestingly, it's both an anesthetic, so it can put you right out, can put you to sleep like a general anesthetic, but it's a much better analgesic. So an analgesic is a pain reliever. So Entonox is a little bit of a general anesthetic drug, but it's a very good pain reliever drug. It's inhaled. And it's generally pretty safe, but you can see in the photo on the left, there's a card there that we have pasted to our Entonox bottle, and it's printed up on both sides. There's quite a long list of reasons not to give it. So when you get right down to it, it's usually just safe for patients with extremity, so arm or leg injuries. Anything in between, head injuries, generally not safe, and there's quite a long list of other potential reasons not to give Entonox. I have a hard time remembering all of them, but I've seen it in action quite a few times, and the responders do a great job of going through the checklist. For us, we just keep the checklist literally pasted to the bottle, so our responders, if they've got other things going on, they can just read the checklist on scene. It's not very portable. That's my 28-liter little BD pack there. And on the right, you can see that's our Entonox kit right there for K country. Hoses, an O2 sat monitor, and the bottle itself. So you can't exactly put that in your back pocket. It has a few other disadvantages using it in the cold and so on. It's generally safe. It's a really good medication, but it has some limitations. So we'll talk about Penthrox. Penthrox is the brand of this drug methoxyflurane that's come to Canada now. It's pretty recent that it's been approved for use in Canada. It's only right now in Canada for 18 and older, so it has a long track history in Australia. A pretty safe use in a whole variety of contexts, including sort of mountain rescue or first response. Its effectiveness, I don't think is particularly better or worse than Entonox. I think they're considered about equivalent. In terms of onset of action, it's fairly similar. Maybe takes a tiny bit longer than Entonox to get peak effectiveness. When you stop puffing it, the effect goes away fairly quickly, in the order of a few minutes. But it has some definite limitations as to how much you can give, because it has some rare but very serious side effects. When this drug was first developed, it was used as a general anesthetic in full anesthetic doses, and unfortunately it was found ultimately to be quite toxic to kidneys and livers. So it's those side effects are pretty rare if it's used at these low levels, the way we're using it with the green whistle, but it does have some serious restrictions. The great thing about it is that one does fit in your back pocket, so it's super portable. I think probably fairly easy to use, although the drug comes in the little bottle that you see in the photo on the right there, a little 3 milliliter bottle. So at -30, you have to take your gloves off and pop the cap off of that, separate the whistle and pour the drug into it, reconnect it, and then get the patient puffing on it. As a first responder, if you use this a lot, if you can smell it, you're being exposed to it, and you don't want to be exposed to this drug, day in and day out, over and over and over again. So in the ambulance, you have to roll down the windows, or maybe the same in a helicopter. If you probably shouldn't be exposing first responders to this drug repeatedly. Some of the serious side effects tend to happen during longer-term use with this drug. It has some strange serious side effects as well. One of them is called malignant hyperthermia, and it's a rare but very deadly metabolic reaction. I've seen 2 cases of that in the operating room over 30 years. It can also happen with other similar general anesthetic agents. So it's not that it's not possible with Penthrox. It's so rare that it probably wouldn't happen. But how comfortable would you feel taking a history for malignant hyperthermia, or a family history, or a patient history for kidney or liver problems? So those are all potential concerns with Penthrox. So its serious side effects are arguably maybe a little bit worse than those with Entonox. This checklist here is courtesy of Jeff Burko from Peaks Medical. This is on their website, so you can actually access this document through their website, so it's available publicly. But the point of showing this slide is that there's a lot of do's and don'ts with both Entonox and with Penthrox, so they're roughly equivalent in that sense in my mind. So if you do think you want to use these types of medications at your operation, you need to have advanced protocols, and you need to have medical oversight in the form of an operation like Jeff's operation, maybe plus or minus a medical director. So that's also quite a long list, and with the Penthrox, you can also paste this type of list to your Penthrox kit if you need to. And you can see towards the bottom there, malignant hyperthermia. And so you'd have to ask yourself, like, how comfortable am I taking a history for that sort of thing, not having experience with it. Another potential concern would be with pregnancy or an unsuspected pregnancy for female patients. Entonox is probably safe. But methoxyflurane is definitely not safe. So that raises some concerns for female patients in the field as well. And then I thought we should talk about some of the really strong drugs, mostly to say that these drugs are the way that we, with medications, treat severe pain. So these are all of the strong drugs. They're very effective for treating severe pain, but they also have very common and very potentially severe side effects. So to use these drugs, in my mind, these would only be available for use by advanced providers. So that would be, say, for example, an advanced care paramedic on your team, or a physician, on the hill kind of a thing. The complications with these types of medications are tough to monitor for, and when they happen, you need full airway capabilities. You need a lot of hands on deck and a lot of equipment if something goes wrong giving these types of medications. The other medication on this slide, or the medication on this slide that requires an additional mention, would be fentanyl nowadays, because we have a fentanyl epidemic in Canada and many countries over the past couple of years. It's leaving everybody maybe a little concerned about the appropriateness of using fentanyl as a pain management drug. So there's a couple of two or three sides to that coin, I guess. Fentanyl's been used for a long time as an anesthetic drug, and it's tremendously effective, and it is quite safe. The usage of fentanyl in anesthetics in hospitals has not gone up really at all the past few years, while the epidemic has skyrocketed. So using it medically is not, in my mind, linked to the epidemic particularly, but the whole medical community is taking a really hard look at how opioids like fentanyl and morphine are used in medical care, especially for chronic pain. So they're used with due consideration nowadays. So again, I think if you're thinking, well, maybe fentanyl lollipops would be a great way, or fentanyl nasal drops would be a great way for us to manage pain for a few of our subjects, you really probably have to have a physician on board. Ideally, the Sunshine Medical Director, Jamin, is an anesthesiologist. He's a colleague of mine at the Children's Hospital. So having someone like that on board might open up those sorts of possibilities. But it's quite challenging, and the way those drugs are controlled nowadays makes storing and administering them also quite challenging. The fentanyl epidemic is very real. It's it'll be 2 o'clock here soon, and the stats currently right now are that 12 people per day in Canada die from fentanyl overdoses. So it's a guarantee that probably at least 6 people have died already today from fentanyl overdose. So it's pretty hard you can't ignore that. Okay, so I think hoping we haven't been watching the clock, but I'm hoping that we have lots of time for questions. And anybody using the green whistle? I've heard Sunshine and Nikiska have used it this year. And I just heard from Nikki that Island Lake used it. Oh yeah, Kicking Horse, Kyle, you've used it. Anybody want to share their experience with Penthrox? Kyle?
Yeah, we've been using Entonox for a long time, and it's just really inconvenient. It works well at the ski hill, just more hands on deck and easier access. Doesn't work very well in the mountain rescue environment. So we've used Penthrox a number of times this winter with Gadsar and Kicking Horse, and it's pretty simple to administer. It's very portable, and at first it seems like really nothing's happening. In fact, most of the patients we've administered it to, when you ask them, do you feel better? They really say, no, there's no change, yet their demeanor's totally changed, their respirations have dropped, everybody around them is relaxed. It really is a total mood changer to the event. So when you roll in on scene and the patient's screaming 10 out of 10 pain, and 5 minutes later, you can have a real conversation with them. It's worked really well.
That's pretty interesting, the perception from the patient that it's not changing anything, and yet in really, really young children, like a 6-month-old child, of course, you can't ask them what's your pain score 0 to 10. So we actually do validated pain scores on 6-month-old children, but we do it by how they look, like how distressed they look in a set of criteria. So in my mind, that would be kind of similar. Like I think you could guarantee that those patients' pain scores are going down, even though they're reporting that they're still experiencing pain. Yeah, Sunshine and Nikiska both trialed it this year, and they found it helpful in selected cases, I think was the take-home message. So neither ski hill stopped using Entonox, and I would still say that Entonox is their go-to, but they found in a couple of selected cases that Penthrox was super useful. Anyone else have an experience to share or comments?
I don't have an experience to share, but just a couple questions.
Sure.
Is Entonox what we also call the laughing gas?
Yes, it is laughing gas.
Okay.
Yeah.
And
Yeah.
my other question was pen trucks, like how long do they last? Do they have a bad expiry date or? Because some of that stuff, yeah, you have to
Yeah,
get
I-
a new one and then it's expensive and.
Yeah, we use, for Antonox, I don't know if it expires. We use Class D cylinders, and we don't go through them very fast, so I'm not sure it has any expiry. Penthrox, I think, would, but I actually don't know what it is. Is it 2 years? Okay, thanks, Kyle. You probably, if you're going to buy it, you buy it from a pharmacist at a drugstore, so you'd want to discuss that with the pharmacist. As well as the cost and so on, although the cost apparently is coming down. It's getting reasonable now. I think it was about $40 for one of those little vials that I showed. I think it's a little bit less now. So if you had to throw it away after a couple of years, it wouldn't probably be too onerous. Oh yeah. I guess yeah, you have to have the whistle. Yeah. Yeah, maybe the $40 was the updated price in Canmore that Sunshine has negotiated with one of the pharmacies there. Sounds more like it.
A great presentation. Thanks, Don. You
Yeah,
piqued
thanks.
my interest with your true-false question. So why isn't dose per body weight give equal pain relief?
Yeah. It just simply, this is actually a really good question, and it's a really hard question for me to answer because I was trained that it does, period. And that was my expectation, practicing as a surgeon for the past 30 years, and I'm really having a hard time shaking that, And I sometimes have a really hard time understanding in my head why, one person with a broken ankle, their pain is 20 out of 10, and their screaming kind of tells us that. And another patient will report that no, that it's okay, they're 2 out of 10, and they're pretty sure they can walk it off. But it's the same fracture. You look at the X-ray, it's the same fracture, and so pain just doesn't work that way. And I think the reason the equivalent morphine dose doesn't work the same for everybody is there's no pain speedometer. So the one patient, maybe that 80 kilogram patient, maybe in their mind, it is daytime and it's a 4-lane highway for them, and they've experienced, similar pain in the past, and they know they're going to get through this. Their age might be different, et cetera. And for the other patient, in the 50 kilogram patient, maybe in that patient's mind, it's actually like 2 a.m. and it's driving snow, and it's the 2-lane highway, 97A, near Sycamoose, that sort of thing. So the morphine is just not going to work as well for that patient whose pain speedometer says they're going 100 and 140, on that icy highway. Yeah, so nowadays, as a result of that, we actually titrate pain quite routinely. So I almost never, for kids after I do, say, a cleft palate repair or something like that, I never order, 0.1 milligrams per kilogram of morphine every 4 hours by the IV. What I actually order is a morphine drip, 0 to 40 mics, and it's continuous. And the RNs come in and they do pain scores on my patient repeatedly, and they'll raise or lower that drip of morphine from 0 if my local anesthetic is still working, and maybe all the way up to 40 mics, during that first night when the babies can be quite distressed. So the RNs are actually managing their pain by titrating the drug dosage that's being given. And they can individualize that to, individual pain scores. So it's kind of one more reason, like understanding pain that way is one more reason to do pain scores. When I started with K-Country, I think 7 or 8 years ago now, one of the first lectures we did was just pain management, because it was the one area when I started as the medical director that our team, we had no structured approach to pain management. My guys were actually pretty good at it. They're actually really good at it, but we didn't have Antonox, and they wanted it. So I made them learn pain assessment before we gave them pain treatment in an Entonox sense. But I also gave them structure for pain management, and hence Mike's big win with the iPhone game and the distracted child with the hip, going from score of 10 to a score of 5. That was one of those sneaky good questions that cuts right to the heart of the whole thing.
Earlier, you were mentioning that sometimes you'll administer Tylenol to patients before the general anesthetic. And I was wondering if you've ever ran into cases where a patient's been administered something stronger, like a T3, prior to surgery, and if you've run into any complications with that.
Yeah, Tylenol 3 or T3s, that's Tylenol plus codeine. With each tablet usually has 30 milligrams of codeine for T3. That's kind of what it stands for. No, we don't use codeine anymore in the pediatric hospital. Codeine, strangely, the way it works is you metabolize it and you break it down and it becomes morphine. But in the process of breaking it down, there's a weird, rare metabolic glitch that can lead to severe toxicity and overdose. And it actually it can happen in adults, although it's super rare. It does happen a bit more in children, or at least the consequences are higher in children. So we no longer use codeine in pediatric hospital care. It got canceled because of this uncommon but extremely serious complication. Yeah, but I guess the better way to paraphrase that question would be, what would happen if the codeine was safe and we used it in that sense? Actually, I think it would probably just work a little better. So as part of a child going to sleep, most general anesthetics do have medications like codeine in them. So while the child is under general anesthetic, they are typically getting that type of medication. It's fairly routine. And then if they have severe pain when they wake up, like if it's a bigger operation, they're usually getting those types of medications in a titrated fashion as well.
I don't know your experience or anybody else in this room that has Penthrox out there, but it seems like one of the major advantages, given the severity of the situation, but for a backcountry lodge, it seems that Penthrox can buy you more time than Entonox. They can go through a bottle of Entonox, it seems way faster, whereas with good coaching, pending the, whatever the pain level is that you'll actually get a longer period of time, which for a backcountry lodge is a major asset.
Yeah, this is one of those great practical, just deadly practical questions or issues. Yeah, the Class D tanks that we use, yeah, how long do they last? If a patient is sucking really hard and really continuously on that tank, maybe an hour. So usually our extractions are faster than that, but not always. So we rarely would have to think, like, where's the next tank coming from with Entonox? Whereas with Penthrox, now, so the drug maker would say it lasts for an hour, but I don't think it actually does. It's probably kind of in your system for much, much longer than that even. Oh. It works. So with Penthrox, once the patient stops puffing on it, it probably only is like super effective for just a few more minutes, maybe up to 5 minutes. And then its effectiveness would start to drop off quite substantially after that. It's supposed to take, I think, about 20 minutes, or the puffer should last and be delivering some drug for maybe up to 20 minutes. And you are allowed to repeat the 3 milliliter vial once at the 20-minute mark. And interestingly, after that, you're not actually supposed to give the patient any Penthrox for up to, most people say, 2 weeks, like 15 days. So because of the risk of toxicity. So if you had a really lengthy extraction, like an hour or more, yeah, I think both of these medications would have significant limitations. Like you're not going to be able to spend all night with a patient tied up at a lodge, to get them out the next morning type of a thing with either of these drugs. You'd have to think about some of the other strategies. Yeah, Tylenol or ibuprofen, if it's safe to give those, might be a better strategy. They're probably somebody's got them in their pocket at the lodge. Might help you out quite a bit overnight as baseline.